Welcome everyone. We'll get started in 1 minute. All right, it's 2 minutes after 12, so we'll get started. Welcome everyone to our November edition of What's New in Addiction Medicine. My name is Paxton Bach. I'm the Program Director for the Addiction Medicine Fellowship and one of the physicians at St. Paul's. It's my great pleasure today to introduce our speaker, Dr. Geneviève Kerkerian, who is one of our current addiction medicine fellows. Dr. Kerkerian is one of our fellows at the BC CSU, as well as a graduate of the University of Calgary Infectious Disease Residency Program, along with having been a past graduate of the UBC Internal Medicine Residency Program. She's passionate about patient advocacy for vulnerable populations, particularly in the context of overlapping infections and addictions. In the future, Dr. Kerkerian hopes to help improve access to outpatient IV antimicrobial therapy for patients with active substance use disorders, as well as take an active role in the care of patients with HIV, hepatitis C, other STIs, and concurrent substance use disorders. Dr. Kerkerian is joining us today to talk about, to deliver a talk called Under One Roof, the integration of infectious diseases care for people with substance use disorders. With that, I will let you take it away, Jen.
Awesome. Thank you for the introduction, Dr. Bach. So I'm really excited to be joining you virtually today. We will be looking at two of my passion at work, integration of infectious disease into substance use disorder. So let's get started. Before we start, I would like to do a land acknowledgement. I respectfully acknowledge that I am a humble guest on the unceded traditional territory of the Musqueam, Squamish, and Tsleil-Waututh Nation. While we are all gathered today on different lands and with everything that's happening these days, I would like to invite you to be mindful of which unceded traditional territories you're on joining me today. I have no conflict of interest to declare. So the plan for today is to review the burden of sexually transmitted and bloodborne infection in people with substance use disorder, and then look at recent data supporting the incorporation of infectious disease care into addiction medicine practices. This is a broad topic, so today I'm going to focus on the outpatient infection that can be treated in a clinic setting, but this is just an opening for more talks. So first of all, well, Dr. Bach did a good introduction, but I wanted to introduce myself a little bit more so you understand where I come from. I'll focus on my professional background. I've trained in internal medicine here at UBC, and then I moved to Alberta to do my infectious disease training in Calgary. And I'm an addiction medicine fellow. And one will think, you know, why would someone who trained in infectious disease want to further specialize in addiction medicine? And other might think, oh yes, this totally makes sense. So hopefully we can move everyone towards the yes, it totally makes sense and have more people also taking that path. My goal today is to illustrate why when I did my infectious disease training, I thought there were missed opportunities in engaging people with substance use disorder in care. And why now, as an addiction medicine fellow, I believe we can further improve the health of people with substance use disorder from an infectious disease prevention and treatment lens. Thankfully, I'm not the only one thinking that way. In infectious disease, we often talk about the source control principle, or going to the source, which means that in order to treat an underlying infection, we have to go to the source. For example, if someone has a diabetic foot infection, we have to address the diabetes. We can't just ignore it in order to treat the infection. Someone who has an intra-abdominal abscess, we need to do surgical intervention or drainage to treat the infection. We can't just give antibiotics alone in most cases. If there is a hardware infection, for example, we need to address the underlying hardware that's infected with surgery or washing. So this is going back to the source, and this concept is very important in infectious disease, and it helps us cure infection. It applies to people with substance use disorder, I would say. If we do not acknowledge and treat the underlying substance use disorder, we cannot achieve proper source control of most infection in people with substance use disorder. And the question comes down to how to do that. This paper I'm showing here came out in Clinical Infectious Diseases, which is a good journal in infectious disease. And this paper documents and pushes the idea that infectious disease physicians are increasingly responsible for management of infectious complication of substance use disorder, and that successful management of these infections requires acknowledging and treating the underlying substance use disorder. Hence a call for a new subspecialty within infectious disease to help within substance use disorder epidemics. This is another article supporting that idea. It's called Beyond Antibiotics. It's a practical guide for the ID physician to treat opioid use disorder in the setting of associated infectious diseases. And they argue that ID physicians are often the first and the last touch point with patients with substance use disorder, especially those with opioid use disorder and serious infection. Sometimes ID physicians are the only one who see a client at the HIV clinic, the hepatitis C clinic, an outpatient antibiotic clinic, STI clinic, general ID clinic, or an inpatient that does not have access to addiction medicine services, for example. So if comorbid opioid use disorder is diagnosed, if there were more infectious disease doctors that were trained in the field of providing medication for opioid use disorder, then it could be an opportunity to deploy the medication and then an opportunity to engage in care. So now let's go through the core topic of today. I will focus on the sexually transmitted and bloodborne infection in people with substance use disorder. And with that in mind, I'm going to focus on HIV, hepatitis C, syphilis, gonorrhea, and chlamydia. The information is probably less new for HIV and hepatitis C, for people attending this talk today. But I hope that I'm bringing new information with the data around syphilis, gonorrhea, and chlamydia. So as an overview, HIV is the virus that causes the acquired immune deficiency syndrome, AIDS. HIV is transmitted through contact with infected blood or bodily fluid. These contacts can happen through unprotected sexual intercourse, sharing needles, or other injection drug equipment. Nowadays, we have access to effective treatment. It's called antiretroviral therapy, or ART. And while it's available, there is still significant barrier in care that remains. There is a concept known as HIV care continuum, and this is what the picture shows here. And this concept looks into every step from infection to diagnosis, to linkage to care, to receiving medical treatment, to retention in care and continuing to take that medication, and then achieving viral suppression. There's no cure right now for HIV. So the goal for treatment is to achieve that viral suppression, which we know has good outcomes for people living with HIV. It reduces the morbidity, mortality, and it also decreases the risk of transmission to others. So it's estimated that since the beginning of the HIV epidemics in the 1980s, substance use and HIV have been linked. Today, illicit drug use or substance use is an important driver of the HIV epidemic across the globe. Substance use affects every step of the HIV care continuum that you see here. So knowing that we have good treatment and we can prevent negative outcome for people living with HIV and prevent transmission, we need to think about how to close the gaps in care for people with substance use disorder. We often think about injection drugs being the one way to impact the HIV transmission and care, and that cascade of care or care continuum. However, there are recent studies showing that many substances have had an association and impact on HIV transmission and engagement in care, as well as preventing the successful virus suppression that we want to achieve. Unhealthy alcohol use, benzodiazepine, stimulant use, opioid use, all have been associated with potentially negative effect on the HIV care treatment. Substance use has also been associated with high-risk sexual intercourse, which can be associated with HIV transmission as well. As we know, substance alter judgment, inhibition, and hence impulsive and unsafe behavior. It's recommended nowadays screening for substance use disorder in routine clinical care for people living with HIV. Now, looking specifically into injection drug use, from the Public Health Agency of Canada, data from 2018, but published in December 2020, they estimated that person who inject drug is 59 times more likely to get HIV than someone who does not. 13.9% of new infection in Canada were in people who inject drugs in 2018. This went up from 12.9% in 2016. And then the prevalence was 14% in 2018. Again, as a reminder, the incidence looks at the new infection and the prevalence looks at the proportion of population living with HIV at a point in time. These number varies across provinces. A few years ago, the prevalence of HIV in someone who inject drugs in Saskatchewan was 79%, compared to 19% in BC or 17% in Alberta. This is not negligible at all. Now, looking more globally, the WHO estimates that globally there's 11 million people who inject drugs. 1 in 8 of people who inject drug live with HIV. 39.4 lives with a viremic hepatitis C infection, so active hepatitis C infection. 1 in 3 hepatitis C death globally is associated with injection drug use. And there's 2.3 million of co-infection of both HIV and hepatitis C worldwide in people who inject drugs. Now looking at hepatitis C trend in Canada, this is surveillance data from 2019 published in July of 2021. And these data overall shows that there were 11,000 more or less cases of hepatitis C reported in 2019, which is equivalent of a rate of 30.4 per 100,000 people. Overall, as you can see, the trends are coming down and there's a decrease in national total hepatitis C rates since 2018. But there's still a lot of people living with hepatitis C that we need to address. Specific to people who inject drugs, almost half of the new infection in 2017 were in someone who inject drugs. Nowadays, we know that hepatitis C treatment and substance use disorder is safe and effective for people who inject drug. It's not contraindicated. Ongoing drug use should not preclude access to hepatitis C care. And treatment should be provided in context of comprehensive care, which mitigate ongoing risk activity, which mean including harm reduction, opioid substitution therapy when indicated, promoting engagement in care, treatment adherence, optimizing social and medical comorbidities. This is older data, but this is a nicely done retrospective study in Vancouver done by one of our colleagues, Dr. Young, looking at hepatitis C cascade of care. And this basically shows that we have a lot of work still to do to treat people who inject drug with active hepatitis C. They look between December 2005 to May 2015 And it did that cascade of care that I was talking about for HIV. And just looking at treatment completion, only 4.5% of 1,500 people who inject drugs had ever completed treatment. Now, it's a few years ago, but still only 6 years ago. It shows that we know now treatment is safe, it's effective, but we have work to do to close those gaps in care and provide that treatment. Now let's talk about syphilis and the concern associated with substance use. If you're not aware, I'm going to give a spoiler, but syphilis is on the rise. This is the epidemiology of syphilis in Canada, data published in 2019. Sorry. And the syphilis line is this one, the yellow arrow, and you can see that from 2008 to 2017, there has been an increase in infectious syphilis, and I'll tell you a bit more about the comparison. Next slide. But there's been an increase in 167% since 2008. When we talk about infectious syphilis, we refer to the syphilis that is associated with a risk of transmission, or contagious syphilis, in other words. This is a figure illustrating the natural history of syphilis. If syphilis is left untreated, then the infection can progress through 4 stages: primary syphilis, secondary syphilis, latent syphilis, which is divided into early or late latent, and then tertiary stage of syphilis. The infectious syphilis stage are the ones that are associated with a higher risk of transmission. Looking at primary syphilis, the incubation from the time of exposure to developing the disease is about 3 to 90 days. And it's usually a chancre or a lymph node, and it's associated with 60% transmission per sexual partner. It's easy to miss, and people often don't know that they have it because that chancre or that lesion, it's a non-painful lesion. Usually it's at the site of inoculation of the infection. Can be found in the mouth, it can be found in the genitalia, but it can be missed. So if missed, then there's a 60% chance of transmission per sexual partner. Secondary syphilis is that second stage. And from the time of exposure, the incubation period is 2 to 12 weeks. It's also estimated to have a 60% transmission risk. This one is also very non-specific, so it can be missed. Can present as a great mimicker, rash, fever, malaise, headache, mucosal lesion, lymph node enlargement. It's not very specific, so it can be missed. Early latent is also another one that's considered infectious or contagious syphilis. And this one is defined by a positive serology, so the positive blood work, less than 1 year after the exposure. It's usually asymptomatic. The people don't have symptoms. It's considered infectious because 1 in 4 cases can relapse to secondary stages manifestation, which is then associated with that 60% transmission that we talked about. So the fact that it can be hard to be diagnosed just based on clinical assessment only makes screening even more important, thinking about it and screening for it. Now that we know the definition, let's continue to look at rates. These are rates per province per 100,000 population. And you can see it's in the high red, very dark red here. It's going up. And the goal, the national goal, was to keep the rates below 0.5 per 100,000 population. We're far from that in most provinces. BC is not spared. This is the rate per 100,000 population. Again, this is in the rise since 2008. We can see that curve going up. And now looking at the Organization for Economic operation and development countries, Canada is not the only one with syphilis on the rise. You can see the blue line is the United States, Australia, England. Canada is here in red, and then you have the European Union there. Those worrisome trend is also associated with more cases of syphilis in women, and that have in consequences led to increase in congenital syphilis rate in Canada. In 2017, it was estimated that the rate was 4.6 per 100,000 live birth. This was doubled compared to previous rates. It's now estimated that in 2019, the cases will exceed about 50 cases total. This data is not available to us yet, but from preliminary report. And these numbers are worrisome and should not be that high in our developed countries with access to effective treatment and effective testing. It should be closer to 0. When I say congenital syphilis, that is a disease that occurs when the mother has syphilis and passes it to infection to the baby during pregnancy. It leads to major health impact on the baby. It can cause miscarriage during pregnancy, stillbirth, so baby born dead, a baby born early. If the baby survived the infection during pregnancy, then as a neonate, as a newborn, it can cause deformed bones, severe anemia, yellowing of the baby with jaundice, brain and nerve damage like blindness or deafness. So it's important. What about rates of syphilis and substance use disorders specifically, looking at our clients and our population? Is there an association? The CDC looked at that question and released this report in the Morbidity and Mortality Weekly Report, looking at association of substance use and infectious syphilis rates. Overall, they found an increased rate of infectious syphilis in women and men who use drug. They looked between 2013 and 2017. They found an association with methamphetamine, injection drug, heroin use among women, heterosexual men with primary and secondary syphilis. This was not a causative analysis, but there has been a link and association that is worrisome and increasing in case with syphilis in the US. What about rates of syphilis in Canada with substance use? So the Public Health Agency reports an increased risk of syphilis with problematic or unhealthy alcohol use, prior link with cocaine use, which has not been replicated in recent studies, injection drug use had that association, and then crystal meth. So to me, when I see this reminds me and reminds us again that although opioids and injection drug use is associated with increased risk of syphilis, it's not just specific to it. So we can think about it for multiple other substances too. And this is going back to the increase in congenital syphilis in Canada, specific to pregnancy and mother-to-child transmission. There has been a link with unhealthy alcohol, methamphetamine use, and increase in the rates of congenital syphilis. This is among other very important factors such as income, remote rural residency, stigma, discrimination, younger age, again, inadequate access to care. So it's not alone, but there has been a link to consider with substance use as well. Now let's look into chlamydia and gonorrhea. Gonorrhea and chlamydia has been on the rise as well in Canada. There's been an association with alcohol and drug leading to increased rates of high-risk sexual behavior, and I'll explain what that definition means. It is then linked to increased risk of gonorrhea and chlamydia acquisition and transmission because of those higher risk sexual behavior. Most people, if they do not do routine sexually transmitted infection screening after having a new sexual partner or after not using the condoms, they might get infected by gonorrhea, chlamydia, and have no idea that they are infected because there are high rates of asymptomatic individual, meaning people without any symptoms, that would tell them that they should get checked, that they have an infection. So these high rate of asymptomatic transmission or asymptomatic cases leads to more transmission. And it's unfortunate because it's in general very easy to treat and curable. And treatment leads to prevention. Specific to chlamydia, so chlamydia is actually the most common diagnosed and reported sexually transmitted infection in Canada. It's estimated a rate of 363.2 per 100,000 population. And there was a total of 117,000 cases in 2018 with chlamydia. It's also on the rise since 2009. It's been an increase of 40% in cases. It's been reported in primary 15 to 29 years old, so younger age group, 76%. And then some cases also between 30 and 59 years old. Gonorrhea is also on the rise, and rates have been increased by 190% since 2009, and by 241.9% among men. There were 30,000 cases of gonorrhea in 2018 that were reported, and it's slightly older individual. It's still majority in 15 to 29, but you can see more cases between 30 and 59 as well. What is considered a high-risk sexual behavior? And these are some definition. They're not absolute, but it's kind of how you triage who should get more frequent testing or not. Some of those definitions from specific to British Columbia and when to get tested would be unprotected sexual intercourse, including from mouth to genital contact, including unprotected anal intercourse, starting sexual activity at younger age, having multiple risk partner, having what is defined a high-risk partner, intercourse with a partner who inject drugs or had a history of injection drug use, chemsex, which I'll talk about it, and sex trade work. And the red here is just to highlight the two that we're interested more in for the purpose of this talk. This is more specific to our population. This was a survey that was administered to about 2,300 people who inject drug in 14 sentinel sites in Canada. They look at condom use during vaginal or anal sex in the past 6 months with a regular partner or with a casual partner. And it was reported inconsistent condom use for vaginal and anal sex in the past 6 months at 59.2% with a casual partner, and then 84.9% for people with a regular partner. You have to keep in mind condoms are not being used in majority of time. This is a concept to be aware of, and it's called chemsex, chemsex or party and play. And it's a term used to describe the planned use of certain substance for sexual encounter. There's no precise definition of chemsex that exists, but studies have investigated the use of many different substances to enhance the sexual pleasure, decrease inhibition related to particular sexual act, combat low self-esteem. It was initially more described in men who have sex with men, but now it's more widely spread and used. Again, chemsex can be practiced safely, but there has been an association in the literature for higher HIV, hepatitis C, and bacterial sexually transmitted infection if not done safely. Transactional sex is another concept that we should be familiar with. It was not precisely in the list of the high-risk behavior that I showed, but it's an important concept to be aware and maybe discuss with the client that we see in clinic and offer sexually transmitted or blood-borne infection testing if appropriate or if wanted. So the definition of transactional sex is a non-marital, non-partnership, non-commercial sexual relationship motivated by the implicit assumption that sex will be exchanged for a drug or money to buy drug. It's different than sex work, and it's usually people practicing traditional sex do not identify as sex worker. And this has also been associated with increased risk of HIV and sexually transmitted infection. So this will conclude the first part of my talk, but there's 3 learning points, or 3 points, if anything, that I would like you to leave with. Hopefully I was able to convince you that patients with substance use disorder are at risk for sexually transmitted infection and blood-borne infection. There's a dual epidemic in Canada for substance use and sexually transmitted infection and blood-borne infection. It's important to think about it for all substances. Do not discriminate. If you see someone, they haven't had routine testing, let's just do it. Now let's review and move on to the second part of the talk. Let's talk about integration of care. What does that mean? What does it look like? Is it beneficial for people with substance use disorder? First, let's just see what is integration of care. What is that definition? And I have a definition from the World Health Organization. Their definition is that integrated care is a concept bringing together inputs, delivery, management, and organization of services related to diagnosis, treatment, care, rehabilitation, and health promotion. And integration is a means to improve services in relation to access, quality, user satisfaction, and efficiency. This concept is not new in addiction medicine. As early as the 2000 and even earlier than that, I found study reporting integration of care for general medical care and addiction medicine treatment. Then there's been a lot of data that came up into integration of mental health and addiction medicine treatment. In the late 2000, early 2010, this is when the concept of applying harm reduction for HIV, hepatitis C, there's been more literature around that. And then HIV and opioid use around the 2010. And then more data coming later for hepatitis C treatment in people who inject drug with concurrent addiction treatment. This is one example of integration of care for HIV and substance use. There's 2 different models that they look in a systematic review of multiple different articles. And they looked at doing the addiction medicine screening and treatment within HIV facilities, or doing the HIV screening and treatment into the substance use facilities. And both overall shows encouraging finding, improving detection rate and initiation of treatment for both. This is a model looking at integration of hepatitis C care into opioid use care. This study was looking at concurrent initiation of hepatitis C and medication for opioid use disorder in people who inject drug. The rationale for this model was based on recent studies that have found that higher rates of sustained virological response, or SVR, you can see here, are possible in people with opioid use disorder. SVR is the indicator that we look at for the successful therapy of hepatitis C infection. Remember when we talk about viral suppression in HIV, it's similarly looking at the viral suppression at the end of treatment. But the difference with hepatitis C is that the undetectable at 12 weeks after completion of therapy is linked with cure. In this study by Rosenthal and al., I'm showing here, they found that people who were on opioid agonist therapy or opioid substitution therapy versus people that were started on opioid substitution therapy and retain at the time of the initiation of the hepatitis C treatment were more likely to achieve SVR compared to people who started stop OAT or were never on OAT. So you can see here 90, 92% compared to 63, 64, 50. So big difference. So their conclusion is that concurrent initiation of opioid agonist therapy with hepatitis C treatment can result in high rates of sustained virological response while reducing the risk associated with drug use. And this is another study that shows the high uptake of Suboxone collocated with hepatitis C treatment, showing that integration for both worked. These are recommendations to improve opioid use disorder and infectious disease services for integration response to a dual epidemic. This is to follow the same line of thoughts I've been talking about. It was published in 2020 by the National Academies of Science, Engineering, and Medicine, which was a consensus study report in the US by infectious disease doctor and addiction medicine care provider. Some of the recommendation that they put in there, and there was 26 recommendations, but as a summary, the first one was we need more funding. We need more funding for training and management of co-occurring opioid use disorder, and ID physician for clinician working in a wide variety of settings. So primary care clinic, infectious disease clinic, you name it, all the care setting. And then also advocating for better integrated training of opioid use disorder and ID in health profession. So CME opportunities, more medical school teaching about the integration of both harm reduction, training and services. We need more research in the field to see how to better integrate evidence-based treatment. And then we need to address the disconnect between health and criminal justice system. And this was a little bit more specific to the US, but having more treatment offered for both from an ID point of view and substance use point of view within incarceration and revisiting those laws. So it seems that there is an increasing awareness of the association between the substance use and infectious disease care and effort to integrate both. But these models often address one specific issue at a time. And by that I mean what I've showed studies focus on HIV and certain substances. Usually it's mainly with opioid use disorder or hepatitis C focus. But what about looking at all the sexually transmitted and bloodborne infection care into a substance use disorder care? So this is a paper that was accepted for publication in September 2021, so very recent. It's going to be published next month, I believe, in the Journal of Addiction Medicine. Their study aimed to look at the infection-related needs of patients with substance use disorder initiating care at a low barrier to access program, so similar to a rapid access clinic that we have here in BC or in Vancouver. This study took place in Boston, and they described the proportion of HIV, hepatitis B, hepatitis C, syphilis, gonorrhea, chlamydia, and determined the rates of treatment linkage to care at 9 months after implementation of standardized laboratory panel. So within that 9 months period that they looked at, they had 393 patients initiating care. And of those, almost 85% completed at least one screening test. They had 60 new active infections that were identified through the screening: 1 new HIV, 3 syphilis, 4 gonorrhea, 3 chlamydia, and then 48 cases of viremic hepatitis C. This is what their standardized lab panel looked like. Sorry. Screening for hepatitis A immunity, hepatitis B immunity, screening for active hepatitis C infection, HIV, syphilis, and then doing the urine for chlamydia and gonorrhea. Their conclusions support integration of care. They conclude that patient at substance use disorder clinic or care at a low barrier clinic have substantial unmet infectious related needs, and the result justify the inclusion of a comprehensive infection prevention screening and linkage to care treatment protocol. So one would think, why addiction medicine clinic beside the rates that we just talked about? Remember that paper that I showed earlier, calling for a new subspecialty within infectious disease? Now, I think it goes both ways, and I would call it the other way. Infectious disease, complication of addiction, a call for a new subspecialty within addiction medicine. They're interlinked, they go together. So why addiction medicine clinic? So we all know that people with substance use disorder have suffered from service exclusion, poor fragmented care access, discrimination, shame, punitive loss, suffer from trauma. They had stigmatizing experience and negative visits in the healthcare, which impacted their visit in the future. This is a quote from someone with substance use disorder in New York. They look at us like junkies. Why would I go back, right? Addiction medicine care providers offer a client-centered approach, low barrier clinic access, non-judgmental, non-discriminatory approach, and can have pre-existing therapeutic relationship or develop one over time that can improve engagement and retention in care. Addiction medicine facility in general aim to recognize the unique needs and values and preference for each individual, involving listening, informing, and empowering patients as experts in their own care. This is that same interview that I showed earlier with the 2,300 participants who reported injection drug use at 14 different sites in Canada. And the rate of experiencing stigma, discrimination, ever experiencing physical, sexual, emotional abuse as an adult or by a previous sexual partner is high. This data support my previous slide in showing awful statistic about these stigma, these experience of discrimination and abuse. Low barrier clinic is a way to overcome the significant hurdles associated with initiation of substance use disorder treatment. So what about locally? What have we been doing to address this? So I'm really excited to share some of Dr. McIsaac's data and her team at the Rapid Access Addiction Clinic at St. Paul's Hospital. So as most of you know, RAC is a low barrier clinic offering assessment and treatment of substance use disorder. And the clinic mandate is to provide short-term stabilization of addiction and referral to ongoing care then in the community. And they became aware of the high prevalence of sexually transmitted and bloodborne infection among patients seeking addiction medicine care. And they realized that the screening rates at their clinic was quite low, and there were no clinic screening guidelines on who to screen, how often, what to do, what to screen, what not to screen. So in the end, patient had often difficulty getting to the lab to complete their blood work. So they started this quality improvement project to improve the rate of sexually transmitted and bloodborne infection screening for new intakes that would come to RAC, the low barrier access clinic. And they had an aim to improve the screening by 50% in about 6 months. The goal was to get the screening to be completed within the first 30 days of care. In a few months only, they improved their screening by creating guidelines. So they created a screening guidelines. They hired a triage nurse that could perform phlebotomy. They brought phlebotomy supply card. Then they came up with a pre-printed order sheet to facilitate the process. They linked the collection of urine drug screen that was already done at the clinic with also a collection for gonorrhea and chlamydia in the triage area. And then finally, when they realized there was a big need in a few months, they hired a phlebotomist, so someone taking the blood in the clinic 2.5 days per week. Their screening included HIV, hepatitis B, hepatitis C, syphilis, gonorrhea, and chlamydia. And the changes resulted in higher rates of screening from a baseline of 7% of new intakes to 32%. And this is the earlier data from a year ago, the preliminary data. But there is ongoing analysis of those data, and now they estimate that it's closer to 70% plus. They also realized that there was a large increase in new diagnosis rate, allowing the clinic to scale up the treatment capacity for disinfection. This is just an example of their effective change early in their study. And like I said, it's still ongoing. So this is preliminary data from Dr. McIsaac. But the percentage of new intake completing the year in gonorrhea and chlamydia was about 3% before installation of that program to up to 55% after February 2021. Now it's been ongoing for over a year. This is again early after that implementation from baseline of October 5th to March 6th, so a few months after implementation of the screening program and also after they hired that phlebotomist, they found 52 new cases of hepatitis C, 16 cases of infectious syphilis, 2 gonorrhea, 6 chlamydia. And like I said, now the program has been on the way for over a year. The clinic now, because of that increase in diagnosis, have treatment available in the clinic for gonorrhea, chlamydia, and syphilis treatment on site. And they have a half day per week clinic for treatment of hepatitis C. So far, their conclusion is that co-location or integration of care for those services improve access to care. And the screening for sexually transmitted and blood-borne infection is an important aspect of care in addiction medicine. This is what their screening guideline looks like, and I'll just pay attention to the one we talked about, the infection that we talked about. And this is a work in progress, but as of now, they do it for initial visit and at least annually, or more often if there's ongoing risk factors. This is a great model, and in my perspective, would be beneficial to be replicated in all other RAC, as well as increased screening in our inpatient, maybe at the old clinic, maybe in detox unit. I see potential for all of it, but I know we can't just clap our finger and then make that happen. It's actually complicated, and there are challenges to implement the integration of care. The clinic is already busy, the staff working is burnt out. We're in the midst of a pandemic. We need funding, money. It's always an issue with money. Education of staff, having staff that's comfortable with the screening, with the diagnosis and the treatment. Maybe a standardized guidelines for treatment, education, addition of routine urine screening for gonorrhea and chlamydia, hiring a phlebotomist, so having a nurse that can perform it, again, increasing the workload, having access to immunization, supply, and train personnel that can vaccinate. But it's not impossible. RAC at St. Paul's was able to do it, and it sounds very successful. So we're getting closer to 1. I'd like to summarize and conclude that hopefully I was able to convince you that there's strong evidence to support care integration. There's a strong link between syphilis, chlamydia, and gonorrhea infection and substance use disorder, and it's okay to think about it and offer screening. And to add to that, if you screen and don't feel comfortable with treatment, call for help, right? Continuously demonstrated link between HIV and hepatitis C infection and substance use disorder. Less new data, but important to revisit that. Opioid use disorder and opioid use as a general is a big player, but there's other substances too that increase the risk of all the sexually transmitted and bloodborne infection. Further research is needed to implement care integration in practice setting to see what is the best model. But overall, in my perspective, in my opinion, care integration is practical, it's patient-centered, and is the future. Working together, we can close the gaps between the dual epidemics of sexually transmitted and bloodborne infection and substance use disorder. And I'd like to finish with that quote from the paper I showed, the National Academy of Science and Engineering and Medicine, stating that integrations tend to improve both substance use disorder and infectious disease outcome as it allows for a more seamless delivery of services between illnesses that overlap. I'd like to thank Dr. Bach for reviewing my slide and helping me with the material, as well as Dr. McIsaac and Dr. Weaver. They've been very helpful in providing me information about the literature and what's happening at St. Paul's RAC. Also, acknowledging Dr. Weaver being the first ID doctor in Canada to take the path of specializing in addiction medicine. Hopefully there's going to be more people in the future. Now I'll open it for question.
Excellent. Well, thanks for that, Jen. Thanks for a very comprehensive overview and for sharing those data with us. I think you made a pretty compelling case. We'll just wait for people to gather their thoughts. You can type questions into GoToWebinar or unmute if you can, if you want to ask it yourself. I'll ask the first question while we wait for questions to come in, if that's okay, Jen. I'm curious, I think you made a really strong case here for this dual specialty and for co-locating these kind of treatments in the outpatient world. Just in 1 or 2 minutes, I want to know what your thoughts are on the inpatient side of things and what role you see for that dual training within a hospital, or if you think that the majority of your kind of value added is going to come in that outpatient world.
That's a good question. Thank you. I think there's place for both. I'll be completely open and transparent. My vision of it is right now I'm working at RAC. I'm doing RAC in Surrey, and I could see a need to just continue to implement that screening and then offer that help with the treatment. One would think sometimes they want to keep the infectious disease specialty for more complicated infection, but I think having both, if you work at one clinic, is a comprehensive approach that you can just do as an outpatient setting. So for example, including in that low barrier clinic, have the clinic where you treat the infection, or provide, just be there to provide support or provide a phone call to a friend, right? Because I think most people are very capable to do sexually transmitted infection. But if it gets more complicated, or if it's out of the scope, then being that point person of that reference, I think I could see a role in that instance. And then inpatient, I would have to say that's the question that I keep asking myself, because I'm a bit over a month into the fellowship and I'm revisiting that every day. I don't know if Dr. Weaver has more experience because she's been a year into, she's been a few months, 6 months into practice of both. I would have to say when I did my one call at St. Paul's, I was trying to integrate infectious disease care, and it's difficult not to overlap and overstep if you're the addiction medicine hat. So it's hard to put another hat, especially if there's an ID service that's already there. So it would be trying to see how we can do it the best. And right now, the way I see it is to talk about screening, and then if you see something in your screening that you do, then refer to the proper person, but at least like doing that first step to think about prevention as a whole. Yeah, but I would have to say I don't have a good answer for you right now because I'm thinking about it every day.
Yeah, I totally see what you're saying. I think that with the proliferation of addiction medicine consult teams, infectious disease consultants at hospitals, that's a question I asked. I feel like the intangibles of just being able to have those two perspectives will still bring value to those teams, even if you're operating in more of a discrete role.
And my approach right now, I've been adding at the end of all my new consults in addiction medicine and into like kind of a infectious disease to consider or screen in substance use disorder. And I just have that vaccination and screening. So that's my role as of now.
A little extra value added to your addiction medicine consult. So I'm waiting to see if there's any questions from the audience. We have time for maybe one more. Here's a comment more than a question from Dr. Weaver. I'm just highlighting that it's that in a smaller setting or a setting where we don't have such access to robust consult services like at St. Paul's, that that combination takes on a whole new meaning, which I totally agree with. I think that would be enormous power to that. And here's just one more comment, and I'll answer the question. It's another thank you, Jen. Thank you so much for doing this work. It's important to provide barrier-free healthcare. Is there any way we can get a copy of this presentation? So these presentations are recorded and should be available on the BCCSU website. Lindsay, I'm not sure if you know when it will be available there.
Yeah, hi, this is Lindsay. I'm the manager for the program. We do post our go-to webinar presentations on a page on our BCCSU website. So you can go and log in and view the presentation at a later date. We post these periodically, so every couple of weeks we will do an update. So please watch for that being uploaded soon.
Okay, so it's 12:59. I'm not seeing any other questions, so I just want to thank you, Jen, once again for such a comprehensive overview. I really enjoyed that. And thank you everyone for attending. We will see you, I believe this is the last one, our last What's New Before Christmas. I'll have Lindsay confirm that as well, but I think we're not back till January at this point. So I hope to see you all then. Thanks for coming, everyone.